So primary concerns regarding the infection in burns are, number one, of course, is the prevention. Then is the surveillance for detecting infections quite early. And then after that, we will discuss the diagnostic part, how to diagnose infection. And then, of course, the treatment part. Treatment part, I will not touch in detail because my speakers following me will be discussing in detail. So catching infection is right. Patient can catch infection right on the spot once he has been burnt or she has been burnt, and then people try to put in either soil or put in something or wrap the patient in a dirty cloth or apply some ink or some creams of their own. So that can be the reason for catching infection on the spot. And second is the during transport. During transport, it is always recommended that a clean cloth should be wrapped, and patient should not be, even if we are putting water on the patient, and just after 10 minutes to 15 minutes, we should wrap patient nicely so that there is no hypothermia, and also it protects the patient from the infection. Then is, of course, in the ER. Many hospitals, they will have the patient first in the emergency room, where the patient is for medical legal reasons and for other inspection reasons is kept without any covering, and many times it stays for an hour or 1.5 hours, 2 hours in such a condition. So one can catch the infection from ER. And then, of course, in the burns unit, we need to be very, very careful about the prevention, like the barrier nursing and other things. So what is the epidemiology of infection we have? We have a source of organism, which can be either the person himself from within the body or outside the body. Then are the mode of transmission, which can be direct or by the nosocomial, by certain objects like bed sheets, beds, and other equipments in the hospital. And then is the susceptible patients. So there are some patients who are suffering from chronic diseases or immunocompromised already. So these three things will be causing infection in a much aggressive way. So then the sources of infection, if we see, the endogenous is the normal flora of the body. Once the patient becomes immunocompromised, that very flora will lead to infection. Hello. Yeah, and then is the exogenous, that is the environment and the hospital kind of things, like the colonized patients. If there is a patient lying in the same unit which is already infected and there is no barrier nursing. Then is the contaminated hydrotherapy instruments. Sometimes we do not clean them properly. Then is the common treatment areas if we do not have a cabin system. Then is the water source. If the water source is not clean, then the contaminated equipments, mattresses, hands and apron area of the hospital staff. Pathogenesis of the burn wound infection is the typical burn wound initially colonized predominantly with gram-positive organisms like staph and all. And then antibiotic susceptible gram-negative organisms, within a week they take over. After that, the wound closure, if it is further delayed, the patient becomes infected, requiring treatment with broad-spectrum antibiotics. And of course, later on, because of the dual reasons of long-term antibiotic as well as patient's immunity going down, there is a yeast or fungi infection, which are quite antibiotic resistant. Then what about the lab diagnosis? Is it the swab, which is the diagnostic, or we need to have a tissue biopsy? So it has been seen that mostly people take a wound swab and that is quite diagnostic. But in patients where there's severe septicemia, in the studies which we conducted twice in our institute, about 100 cases each, the tissue biopsy culture revealed that in cases of septicemia, severe septicemia, there was a disparity between the wound swab culture showing some bacteria and the deeper penetrated deep tissue biopsy cultures. 15% of cases in septicemic cases, the bacteria identity was different. So the wound cultures should be taken at the time of admission and then at least twice a week, which is recommended. And maybe taken, if you are suspecting more infection, maybe taken more frequently. And then it may serve as the unsuspected reservoir for cross transmission. If we means that we would like to know, once the patient came in, he had no infection and later on he acquired infection from within the hospital. And method of wound culture is, of course, the standard semi-quantitative swab as well as quantitative. The factors associated with improved outcome and infection prevention, they include, of course, the early burn excision. Then is the topical antibiotic therapy. Then is the aggressive infection control measures. One of the primary concerns associated with burn injuries is the avascularity of the scar, which preventing the immune cells and systematically administered antibiotics from being delivered to the infection site. So that is the major cause. And there is no question now to say that whether early excision should be done or not. Early excision is the key to prevent infection, and that is absolute yes. The early excision debridement and skin grafting as soon as possible. And systemic microbials, systemic antibiotics, there is a lot of controversy. Some people, some schools say that initial antibiotics should not be started, while the others say that one single cephalosporin kind of antibiotic should be started. At our institute here, we do give initial antibiotics in the form of cephalosporins. In burns which are older than 7 days, there's already a biofilm which is detected there in these areas. And this is associated with chronicity of the wound, and bacterial colonization is easier to eradicate in the first few days after injury, but after 7 days, it becomes a bit difficult. Then signs of wound infection, which are as follows: the suppurative separation of the scar, the graft loss if it was done earlier, the change in the wound color, that the focal areas of red, brown, or black discoloration, then the green discoloration in the subcutaneous fat. Then there are signs of cellulitis, which are as follows: erythema, induration, warmth, tenderness, and sepsis. So these all should be monitored every day by the either the resident or the consultant and the supporting staff. Then the signs of sepsis are as follows: the increased temperature, progressive tachycardia, progressive tachypnea. So these are all because of the systemic inflammatory response by the body. And then the thrombocytopenia, hyperglycemia, and inability to continue the enteral feed. So if any one or in combination they are detected in the ward, it should alarm that the septic patient is going into septicemia. Then there are complications if the right treatment or the aggressive treatment is not begun still by double antibiotics or broad spectrum antibiotics, then it can lead to pneumonia, septicemia, and later on multi-organ failure, which can lead to death. The major cause still in burns is the infection. So laboratory tests which are there, of course, the TLC count, the hemogram, then the C-reactive protein, but these are not very, very specific. Then there's low albumin levels if there is associated with higher incidence of the sepsis. Then, of course, the PCT level is of more than 0.56 per milliliter, have a reported sensitivity of 75% to 80%. So PCT level should be conducted in all the patients, which can have a sensitivity to declare that the patient is landing into septicemia. Then if there are any imaging study, of course, not any imaging study diagnostic of septicemia or infection. Of course, the chest X-ray will show progressive ARDS or patches. Then there are two stages depending on the colonization, which include number one, stage one is superficial. The microorganisms are present only in burn wound surface. Then is penetrating, which is variable depth of the penetration. Then is proliferating, where there are variable levels of microbial proliferation at non-viable or viable tissues interface. Then stage two is when there is a micro invasion present in the viable tissue. Then deep invasion also present in the viable tissue, once the viable tissue is invaded. So early empirical antibiotics, there are certain questions now after we learned all this. There are certain questions whether early empirical antibiotics should be started. Number two, either we should go only for swab culture or a tissue biopsy should be done. And of course, should be early diagnosis should be done. These three questions will be debated. So it has to be a team approach. The surgeon or plastic surgeon is of course the team leader, but the role of nurses and dressers, who can tell you that, look, doctor, there are certain irregularities on the wound and they don't like it. So they would ask this house surgeon, resident, or the consultant. Then of course, intensivist and microbiologist should be consulted at time to time. So the message is that be vigilant and detect infections early. If we can prevent, then it's the best thing. If we can detect early, we can aggressively treat them. So thank you very much.